Can you put something on your social screen?
Takes a USB to change from one.
Look, your station. Click on present solutions.
No, it's just.
I got the email like an hour ago. Not even
I'm just trying to go to the lower Korea.
yeah, I was like, no.
Work.
It's like the small. They're just super
Yeah, I want to go to California.
I don't think it's just me, but I said it's still very
Oh, because it's only one.
Yeah.
I'm just trying to go to that one. It would be like that.
Yeah, why do you not use these words as well? Can you move to the way here?
Is that supposed to be that one?
No, it's just supposed to be here. Okay. I figured out.
So you're this.
Okay, good.
Okay, and your slides will be
It will change. I need to advance them here. I'm just gonna do this. If it's advancing? Oh. It's not.
Okay. The slides are not changing. The slides.
Get rid of, click.
I
click anywhere
can't.
on the-
What do you want me to do?
No, click the slide. Get rid of that.
Okay.
Okay, now it is.
Good, great. Okay, welcome everybody. Today we're very happy to have Dr. Christine Markowski here to give us a talk on cognition and brain development in pediatric Crohn's disease. A little bit background on Dr. Markowski. She's an assistant professor of psychology in the Department of Psychiatry at Harvard Medical School and a clinical scientific associate in the Department of Psychiatry at Boston Children's Hospital. She's also the lead pediatric neuropsychologist of the Cerebrovascular Disorders and Stroke Program at DCH Department of Neurology. Dr. Markowski has a PhD in clinical psychology from the University of Vienna. So thank you very much for accepting our invite today, and we're very excited to be here.
Thank you. Thanks for the introduction. Thanks for the invitation. So, I'm going to be presenting to you research that I've been doing for a few years now. So as a pediatric neuropsychologist, very interested in how brain and behavior relate to each other. And clinically, I see a lot of children who have very significant neurological disease. And research-wise, I've been studying a group of kids that has, on the surface, not really neurological compromise, but has a gut disease, gastrointestinal disease. So I'm going to explain a little bit to you what Crohn's disease is and why are we interested in looking at these kids' brain development. These studies have been funded by NIH with NRSA first and occasionally free, and now we have a foundation grant currently. So the goal is to define how Crohn's disease, behavior, and brain are connected with each other. Then I want to present some of the behavioral studies on the effects of treatment for Crohn's as well as underlying disease on cognitive functions, particularly memory and learning. And then I'm going to be presenting our preliminary neuroimaging studies that have launched into the study that we're currently doing. So what is pediatric Crohn's disease? Has any of you ever heard of Crohn's disease before? So it's one of the inflammatory bowel diseases. it's inflammatory bowel disease, not irritable bowel syndrome, which is different. IBS and IBD often get mixed up. There is another one which I will only touch upon, which is ulcerative colitis. But when we say Crohn's disease, it's really not just one disease. There are many variations of the disease, as very recent genetic research is showing. It used to be really an adult onset disease, so we didn't see this in kids until like a couple decades ago. And then the age of onset, the median age of onset would be during adolescence. But we're now, like during the last 5 to 10 years, we're going downwards, and now kids get diagnosed age 5 and younger. And we have currently a study going on that looks at very early onset IBD, which looks at infants. And
is that just because they're being picked up earlier, or is it the age of presentation?
It's getting picked up earlier, but there's also like a genetic variant that is being recognized now as such, and that's how they're identifying these kids. It's a bit different than the more general IBD or Crohn's, in that the disease course is much more severe. But it used to be not very common because it really wasn't diagnosed very well, but it now affects about 500,000 children in the US, and the incidence rates have been rising. So what is it? It's basically chronic gastrointestinal inflammation, so primarily of the small intestines as well as the colon, but it can be also more systemic, affecting anywhere basically from mouth to the back, and there are also what's called extra-intestinal manifestations. What's important to know is that it has some sort of autoimmune etiology. It's not an autoimmune disease per se, but there's something going on with the immune system that turns into autoimmune and can shut off the inflammatory process. And what's even more devastating is that there's currently no cure. So when you're diagnosed, it's a chronic illness. So just going back a little bit over where it can hit, so primarily in the intestines, but then also patients can develop, this is a little fuzzy, but they can develop oral ulcers, so inflammation in your mouth. You can get uveitis, inflammation of the eye. They can get what's called erythema nodosum, which is like a skin condition. Patients can also have joint pain and joint swelling. There is a comorbidity with juvenile rheumatoid arthritis. And so these are the extraintestinal symptoms or manifestations. And so then the question became, well, if it affects all of these organs in your body, how could it not affect the brain? The main features are that it's a remitting relapsing course. So these patients will have a disease flare, then they might be brought under control. They might stay in remission for a while, and then they can flare up again. The severity of this disease varies based on how well they respond to medication treatment. What's called stricturing disease, which is like a narrowing in the bowel. They have usually more complicated disease course, usually require surgery, and can have complications that are more severe than, let's say, a fistulizing disease or inflammatory disease. What we see most commonly is that kids might be presenting with abdominal pain. They could have bleeding going on, fever, fatigue. Weight loss is one of the hallmark features. Weight loss and stunted growth. These kids may not even have significant bleeding or whatnot, but a child who has growth pupillary or weight loss is kind of a pretty high risk for developing or having the disease. The treatment protocols are currently not standardized, but what the mainstay of treatment is with corticosteroids. Those are very potent anti-inflammatory drugs that have been used in a wide range of pediatric conditions, inflammatory conditions. So usually what they do is they will treat these patients with steroids just to cool down the inflammation, to bring the inflammation into remission. And then they'll start them or bring them over into what's called maintenance drugs. And that could be anything from typical chemotherapy agents that we would use in leukemia or cancer, such as 6-MP, methotrexate. And more newer agents are what's called the biologics, which is the anti-TNF therapies, such as infliximab or Remicade. All of these, of course, are side effects. The primary side effects that we have been interested in studying are the corticosteroid effects, but we don't know, for example, what infliximab could cause. And yep.
Oh, sorry, I just have a question about the weight loss. Is that due to them avoiding eating because they know they're going to feel bad later, or is it just because they have diarrhea and lose water weight in addition to the normal excrement?
It's both basically. So you can just have weight loss because of the diarrhea. You can also have not proper weight gain because of malabsorption, so that you're not absorbing the nutrients the same way than a typically developing child or a healthy child would be. And then the other one is like secondary anorexia, that they're not eating because they're worried about the way how they might be feeling. So, and sometimes it's very hard to tease all of those apart. So we read it, the psychosocial stressors, because they haven't been found to trigger disease, but they can exacerbate a flare-up. So if you're not very well adjusted, you might not be able to deal with stress as well, and that can cause disease to kind of be prolonged. So why do we, So why do we want to study the brain in pediatric Crohn's? Well, I already gave you a little bit. So on the one hand, we have an underlying disease that presents with high surges of pro-inflammatory cytokines. Cytokines are proteins that can be both protective as well as destructive, especially the pro-inflammatory cytokines are mediating the immune response, they're upregulating the immune response in kind of in a more destructive way. We know that some of them, especially like IL-6 or TNF, C-reactive protein, those are kind of like the heavy hitters that can affect the brain. We know that some of them can cross the blood-brain barrier. And excess cytokines have been found to cause light matter damage, as well as neuronal atrophy. This comes a bit from the Alzheimer's literature. So on the one hand, it can affect brain structure, but there's also indication that excess cytokines have also been found to cause what's called sickness behavior, which is basically like this feeling of malaise and fatigue, and can affect the whole cognitive functions, attention, memory, whatnot. And then on the other hand, we have the treatment for this inflammation, primarily with corticosteroids, and we do know that corticosteroids have no neurotoxicity. Excess steroids basically have very corticosteroid receptors, for example, very richly involved in the hippocampus, so they can affect memory and mood, and they can cause apoptosis and atrophy in hippocampal structures. And then on the other hand, we have the psychosocial factors, which the directionality of the relationship is not quite clear at this point, but we do know that patients with IBD or kids with IBD have an increased rate of anxiety and depression, as well as those kids miss a lot of school, so you would think that probably their cognitive development might be affected by that. But again, the direction of this relationship remains to be studied. So what we do know is that pediatric IBD is associated with significant psychological morbidity, as I just said. Increased rates of anxiety and depression have been well documented. The cognitive outcomes, including school functioning, remain understudied, and part of that is because these patients won't present with frank neurological compromise, so they may not come to attention until way later. And so this is why we felt like we want to study that more systematically. One of the things that if a patient, regardless of whether they have Crohn's or not, is being put on steroids if there are some very heavy effects. One of them is the change in appearance. They have what's called Cushing syndrome, kind of like this puffy presentation. The bone density reduces, so these kids are more prone to fractures. They can have all kinds of other organic side effects. And we do know that they can have CNS side effects. So in our very first behavioral study, what we wanted to look at is how acute steroids, so when a kid is on steroid treatment, how that affects the behavioral outcome. And with behavior, we mean anything from cognition to mood, behavior regulation. So in this study, this was a cross-sectional design. We compared patients with IBD, so both Crohn's and ulcerative colitis patients who were on high-dose steroid treatment. So these patients are all 8 to 17 years old. On high-dose steroid treatment, so during an acute flare, 2 patients with IBD who were in remission, and they had to be off steroids for at least 6 months. So we kind of like had the steroids moved out of the system.
How can you differentiate the acute flare effects on cognition from the steroid effects?
I'm gonna get that. Not very easily. But so so what you can very easily, or more easily do is you can design a study that looks at treatment effects. Now, can you design a study that looks just at like various inflammatory levels in patients? Much harder. Okay, so this is where we started out, and we were looking at memory, executive functions, and mood. Everybody knows what executive functions are. Yes, no.
When you
So
some do some
okay.
but
So executive functions are basically, it's a very hot term and everybody's using it, and nobody knows what it really means. It's basically a big umbrella term for a lot of different functions, and we have functions that are called like what we call the hot executive functions and the cold executive functions. The hot executive functions are those that supposedly are mediated by orbital frontal brain regions, and our behavior regulation, emotion regulation, the way how we can kind of like move through the day without getting irritated all the time and whatnot. Those are the hot functions. The cool executive functions are more the cognitive processes that are primarily supposedly mediated at dorsal level prefrontal cortex. That would be being able to regulate your focus and attention, being able to memorize, working memory, judgment, all of those good things. So as you can see, it's like a very wide term, and people a lot of the times in studies that kind of like pick and choose what might fit. So it's a little difficult. So you always have to be a little bit careful when you see something about executive functions. What does it really mean? But in any event, in our case, it really means attention, behavior regulation, emotion regulation, and working memory kinds of things.
I want something. To compare any behavioral study, it is the first diagnosis before the steroid therapy, after the steroid therapy. Any behavioral study to compare it.
That compare patients before they were diagnosed?
It's the first diagnosis before the therapy, after the therapy. To compare it.
I'm sorry, you mean they're diagnosed with Crohn's before
Yes.
before they did a behavioral study? All of them had to be diagnosed before, and we didn't have anybody who would not be
For example,
diagnosed.
it's the first diagnosis, Crohn. This is the Crohn disease.
Yeah.
Did you do any behavioral?
So before the steroid treatment?
Yeah.
No. And the reason, I mean, this comes up all the time. It would be, so a lot of the times the studies are, well, this was a cross-sectional study anyhow, so all of these patients either were on steroids right at the time of when they assessed them, or they were in remission, comparing to different groups. What you are asking is, could you do like a repeated measures longitudinal study looking at kids before they have been placed on steroids and then after they come off? And that is very hard to do clinically, because as soon as these kids have elevated inflammation and may have had a colonoscopy, they will immediately be put on steroids before they might even be fully diagnosed, which makes it very difficult to bring them in for a behavioral assessment for a research study. So we have gone through this because it would be ideal to be able to study steroid-naive patients, so to speak, but it's the practicality of it is hard to do. Yeah, yeah.
I think when you get into these medical syndromes, it's much harder to do clean studies. It's a real challenge because you cannot impact the clinical care, so it's a real challenge.
Right, right. And a lot of the times, by the time we actually get them for the studies, as Lama very well knows, is they have already been on treatment for quite a while. They may actually already be starting to be tapered off. just because it's a chronic illness. They're getting newly diagnosed. These patients or families are going through enormous stress. Like, what does this mean? It's like, oh my God, my kid is chronically ill. Are they gonna die? I mean, there are a lot of questions, with that. But as a researcher, you don't always think about because ideally you want to get them right at this time point. But
what malnutrition can it affect also the all the functions that you're looking at when these kids cannot eat or get
proper nutrition?
Yeah.
Absolutely. Most kids are not really malnourished these days anymore, and yes, malnutrition absolutely affects brain development. But there are more patients who might have malabsorption, primarily like of micronutrients, for example. Like you may not get enough zinc, or you may not get enough iron and whatnot. But it's a rather smaller proportion of kids.
But they're not growing as normally as humans.
They might not be growing as normal. Yeah, during the So once the disease comes in remission, they should be growing normally. That would be the definition of remission. But yeah, definitely. Okay. So in terms of what are we looking at from a neuropsychological perspective when we look at these kids, so these are very standard clinical measures of memory using, for example, like the children, the California Verbal Learning Test, which is this learning task. They're using paragraphical tasks, where you tell the kid a story and they have to repeat it after they hear it, and then after a period of delay. So those are very, very typical memory measures. We also get spatial memory from these kids, where they have to, for example, remember, and this is kind of like cut off, they have to remember an area of these thoughts, the locations of that, and then have to
The exit, I might get rid of that little window.
exit.
So you see the little
Do you
window
see
there?
an exit sign?
Yeah, right there, quick. That helps.
Anyhow, so what they see is this area, and then you give them like chips that they in the grid that they have to reproduce that. And this is a standard like learning task over repeated trials. Same with the list. You give them shopping lists to remember. You give them a list A that they have to then learn over 5 trials. Then you give them an interference list, so just to kind of confuse them a little bit. And then get memory recall after the interference. Now, one of the hallmark neuropsychological measures is the RIAS rate. Are you familiar with that? Resist. It's a visual perceptual task, really of perceptual organization. How well a person can kind of figure out what's going on here, like what's the main feature, what are the details, whatnot. But then there is also an incidental learning task involved in that. So what you do is you give the subject this figure. You say, here, have some markers, copy this. And then after they are done with their copy production, take it all away, and now give them another piece of paper and say, now I want you to reproduce it from memory. But it's an incidental learning task. You don't tell them beforehand that you have to remember it. And what it really gets at is, one, how well can you organize information, which is very important for you to be able to improve and remember it later on. So it gives us more information on the way how people process information, and rather than just the final outcome. And when we looked at the group comparison of these patients, we found that as a whole, the IBD patients didn't really differ on a lot of these tasks. And it's like, wow, that's odd. And then we thought, well, we really have 2 separate disease entities. The Crohn's kids versus the ulcerative colitis kids. They have different underlying disease etiology, different treatment protocols. And we did find a steroid by disease interaction, so we parsed them out, and we were looking at just the Crohn's kids versus just the EC kids. And we did find, for the Crohn's kids only, that those who were steroids perform more poorly than the controls on, these measures that I just showed you, both non-verbal and verbal memory. Both groups equally were doing more poorly in terms of their overall emotion regulation. So what, there was kind of like the first step, and then we kind of like, well, but what does it really mean? I mean, these are acute effects. Are these effects permanent or transient? Do they go away when these kids are on steroids? What else could there be that could contribute to their behavioral presentation? And so we launched into this next study that was looking at these effects more longitudinally with a repeated measures design. And here we had a total of 148 children between 8 and 16 years. And we had 4 groups. We had, again, a group of Crohn's, so on. We only studied Crohn's. We wanted to take out, make the groups more homogeneous. We said, let's just study Crohn's. Let's not worry about, other variations that might happen with UC. And so these are patients who are actively ill on steroids and have high levels of inflammation. We got them during a steroid course, and then after 6 months after cessation of steroid therapy. And then we compared them to Crohn's patients who were in remission, which means they either had no or low inflammation, and they should not have been on steroids. And we did a repeated measures at baseline and 6-month retest. We had an abdominal pain group because we wanted to get like a GI pain group that didn't have all of this underlying immune response. Turns out they're kind of more complicated because the psychological profile is more involved. And then we had healthy controls. And all of those kids got baseline neuropsychological assessment, they all got a blood draw, and at baseline only, and only a subsample got MRI. And then we brought them back for the retest for neuropsych and blood draw. And in terms of like the behavioral outcomes, what we did find, just like summarizing, was that, so here's the baseline, and the red, thick red line are the steroid-treated patients. The purple line are the Crohn's patients in remission. These are the healthy kids. These are abdominal pain kids. What you see most prominently is that the steroid kids actually improve quite a bit in their working memory, in their emotional control after they come off treatment. And the other kids, they kind of like, they cluster together. I mean, you see a little bit of fluctuation always when you have repeated measures. Change, get better with age, get better with the second assessment method, a little bit of a practice effect. But this was kind of nice to show patients, because now you can say, your kid might be on steroids. Parents would just say the kid is like, it's the steroid week, or steroid week right now, because they're just really, really irritable. And they would get better. And so you can tell them, wait until they're off. Hopefully some of the symptoms should go away. Where we didn't find it as much was when we looked at the actual recall, the memory. Per se, this was the list learning task I showed you earlier. I mean, all of them improved somewhat, which was anticipated. But as a whole, the Crohn's group, both active and in remission kids, were doing a bit more poorly than our control kids. And so then the question was, well, it might not just be the steroids, it could be something else with the Crohn's kids as a whole. And so we were looking at that. We were pooling them together. So now we have 85 Crohn's patients, and these are the healthy controls. So the Crohn's patients in purple. And you can see that over a range of memory measures, the Crohn's kids were doing more poorly than the healthy kids. Then you can go like, yeah.
What's the effect size of these improvements? Like, is it a case of like increasing by 1 IQ score, or like 10 IQ points?
No, 10 IQ points would be like huge.
Yeah.
Yeah, usually, I mean, you're looking at maybe like a couple of standard points. So it might be like half a standard deviation, basically, depending on what measure you're looking at. You're looking at IQ or looking at a scale score, which is a little different. But that's usually what you might see. But it's not consistent across all measures. It kind of like depends on the measure too. But we were, and you're hitting a point there that you have to also understand when these kids come to the laboratory setting. This is a very structured environment. The assessor sits with them one-to-one, and basically already is their executive brain. It's very different in the classroom environment. And so we do want to correlate this to how does the functional outcome of these kids look like in the real world. And we're taking a look at their school function. And this is reported by parents and kids themselves. All of those patients, again, just to remind you, were pre-screened for school problems. So if they had a prior history or a diagnosis of a learning disability or depression or so significant emotional problems, they would not be eligible for the study. They also could not be on what's called an IEP, which is an individualized education plan. So they would not have received any, shouldn't have received any special ed services. They could have been on what's called a medical 5 and 4 plan, which basically provides them with recommendations and in those kids' cases, so that they can leave the classroom and go to the bathroom. But when we looked at the reported function, we found that the grown kids as a whole had a much higher rate of reported school problems than the healthy kids, even though they were already pre-screened. And they also got, like 50% of them got some sort of educational interventions, tutoring, special resource room teaching, or whatnot. And that is something that kind of like hits home in the GI community, because the families, the physicians, they want these kids, once the disease is under control, they want these kids to do well in school. And the question is, why are they looking so different? So we wanted to, going away from the steroid question, we wanted to also look at what the underlying disease, primarily inflammation, could contribute. And we were looking at the effects of these pro-inflammatory cytokines on cognition and behavior. As I told you beforehand, there are surges of pro-inflammatory cytokines in IBD. This is a long list of them that is elevated. There is evidence in the literature that chronic elevation of these cytokines can promote neurodegeneration and related cognitive impairment. And IL-6 in particular has been associated with can talk into the brain, particularly the hippocampus, and has been associated with poor cognitive outcomes. So we wanted to look at this in our own data, and we were looking at these cytokine levels based on serum, so from peripheral blood, which still is kind of like an indirect way, because we can't get, we would have to get cerebrospinal fluid to really look at cytokines in the brain, which we're not doing spinal fluid with these kids. So we had C-reactive protein with IL-6 and TNF, and we found that higher inflammation, when we looked at the Crohn's group, was associated with poorer memory and poorer emotional function, quality of life. We also, so this was during the acute phase, meaning like during their baseline assessment. When we were looking at the retest cytokines, we found that chronic inflammation, so if these kids were still high, we found that chronic inflammation could be correlated with more behavior problems as reported by either the kid or the parent, particularly with regards to kids felt less effective, the parents reported more attention problems, more problems with initiation, getting started on something, with inhibitory control. And in summary, in terms of our behavioral findings, we found that both mood and cognitive problems to be associated with pediatric IBD. Steroids have no neurotoxicity, which was reflected in our cognitive data. We found that cytokines to be associated with behavioral function. And the question now is, do these excess cytokines really disrupt brain systems that are critical for these cognitive functions, particularly vitamin gray matter? And that's what kind of like launched us into our neuroimaging study. And again, this was a small sub-study, so the sample size is still relatively modest, but it gives us some preliminary looks. What do we know from the literature is that inflammation does disrupt white matter development. There's a relatively recent report that in adults with Crohn's, these patients have been found to have higher rates of white matter abnormalities than healthy patients. And there have also been some gray matter changes in adults with Crohn's, particularly in frontal and anterior cingulate cortex. And cortical thickness has also been found to be altered in adults with inflammatory conditions, including Crohn's and other inflammatory conditions. But there's really nothing in pediatric Crohn's. So what were our hypotheses? First of all, we just wanted to see whether or not kids who have Crohn's are different in terms of both gray and white matter than the healthy children. So we were looking primarily at white matter organization, protein TI, and cortical thickness. And then the secondary point was is inflammation and steroid treatment associated with these differences? And finally, how does this relate to function, so neuropsychological outcome? So this sub-study consisted of 32 children aged 9 to 14 years. They were matched for age and sex. We had a small sample of Crohn's patients that were doing an acute flare on steroids, and then the healthy controls. And as you can see, the numbers are quite small, but we could draw some preliminary conclusions from that. And the design is the same, and I already presented beforehand. The sample or the groups were pretty comparable in terms of demographics and IQ. As you can see, these kids are quite bright. They have an IQ, mean IQ of 118, 116. High functioning kids that can probably compensate, talk about cognitive reserve. If they have some issues with memory or executive functions, they probably can make up with their brights. What was not different, which was interesting, was didn't experience more pain in this sample. And also not more sleep problems. Usually when you go on steroid treatment, you can have pretty disrupted sleep. But so that doesn't differ, which was good in our case. We didn't have to adjust for that. But what was different, which was anticipated, was their level of inflammation. So their SAD rate, their C rate of protein was higher, which by definition they should have been. So in terms of methods, we have like this a pretty comprehensive neuropsych battery again. And in terms of the sequences we use, we did a DTI with 35 diffusion directions, and then the volumetric imaging was just a standard MPRH sequence at the time. Not yet, boy, it's nice. Can't see the sequence. In terms of the analyses for the TTI, we were doing drug-based spatial statistics. And I'm not sure if you're familiar or know it quite well. But so we're looking at voxel analyses, and then also grading regions of interest where we were calculating mean FAs over certain tracts based on this white meta-atlas. And what we found in a very preliminary way was that FA values in Crohn's patients were smaller than in healthy controls. In the superior longitudinal fasciculus, here, so that here, particularly on the right side, but I think we found something on the left too. And then we found differences in the corona radiata, cerebrospinal tract. This was the voxel analysis. And when we submitted this to the averaged analyses, we found particularly the SLF to be different between the groups. You have the corona radiata, the fornix left and right. But once you adjust for multiple comparisons, we lost some of these effects. And we could just be purely underpowered at this point. Then Chris, who has been doing a lot of work on this, has also run this through Dracula. And what we found here was a similar pattern, that patients with Crohn's, again, showed lower FA values than our healthy controls, particularly bilaterally in the singular mandibular bundle, bilateral onset fasciculus, and again, the right superior longitudinal fasciculus, which is a little bit of a confirmation of that perhaps what we were finding with the other analysis, really is true. And as a very exploratory way, then we also wanted to see whether or not, based on the hypothesis and the literature, can we find information to be associated with white matter. And we did find that for some of these inflammatory markers, like the main hitters here, they were associated. These are partial correlations because the N was so small. Even the regression analysis, wasn't really feasible. But what we did find was pretty significant correlations and pretty robust, actually very robust correlations in terms of higher inflammation to be associated with lower FA in this particular phenotype. What that means as a whole, we don't know yet. We just need more data in order to see how that pans out. Then we also did look at cortical volume and cortical thickness. And in terms of cortical volume, a similar pattern emerged that Crohn's patients had smaller cortical volumes in cingulate, superior frontal, inferior frontal, and superior temporal regions. So pretty widespread. And we did find smaller subcortical volumes in the putamen. And these were all adjusted for age, sex, and interbreeding volume. And then we were looking then at cortical thickness, which was all measured with free surfer, where you are assuming, like your mean cortical thickness somewhere between 2.5 to 3 millimeters, with a range of 2 to 4 millimeters, but that of course changes with age, should get thinner, so we have to adjust again. We found that Crohn's patients during active disease on steroids, to keep that in mind, showed a widespread reduced cortical thickness. So what you see here is lateral view of the left hemisphere, lateral view of the right. All of the areas that are in color are regions basically where Crohn's patients had thinner cortices. And that was really robust, because that was already after we corrected these, adjusted for age and sex, and the post-discovery rate corrections, and we were still at the corrected levels, which still at least below 0.1, if not 1.41. And then I wanted to see whether or not this actually does correlate also with steroids inflammation and functional outcome. And what we found is that when we just looked at very crude mean thickness overall, we found this to be associated, but then also in certain regions, middle frontal, superior temporal, and inferior parietal. So what we found was that reduced cortical thickness was correlated with higher inflammation, with higher steroid dose, so with like a low dose-response relationship, with poor school function and placement on a 5-4 plan. And what you can see here already is that steroids are pretty robust predictor here, which actually did come out in our regression model. Once we entered all of this into a model, we found that steroid therapy was the most robust predictor for cortical thinning. But again, we are looking at CRP here, which is C-reactive protein is an acute phase reactant, which is not that stable. And again, it was measured in serum, so it's peripheral levels, which can change pretty quickly. So we need to look more carefully at our interleukins, which we have, just need to be acid. And then I was also interested as a neuropsychologist at the functional outcome. What does that mean, in terms of these kids' cognitive and emotional functions? And at baseline, we found that cortical thinning was associated with poor nonverbal memory and more mood problems. And interestingly, it was a lot on the right, which sort of is kind of like where you would expect spatial memory to take place. If you can say that in the developing brain. And then we also found bilateral involvement of temporal regions for mood. And finally, we also wanted to see whether this actually pans out in terms of like the more longer-term outcome, meaning how do these kids function at 6-month retest? Even though we didn't have a 6-month MRI, we still wanted to see whether or not the cortical thickness measure we had at baseline would predict some of the more longer-term outcomes 6 months later. And we found a very similar pattern that thinner cortices at baseline would predict poorer nonverbal memory at retest and more mood problems reported at retest. So, in summary, our preliminary data here demonstrates decreased white matter integrity, in particularly the superior longitudinal fasciculus, perhaps temporal limbic fiber tracts, in children with Crohn's compared to healthy kids, decreased gray matter volume, as well as decreased cortical thickness in our Crohn's patients. And inflammation scares can be potential predictors. And in terms of the cortical thickness data, we really found pretty widespread thinner cortices. One thing that was kind of surprising me personally was that we didn't find more frontal cortical involvement, but really a lot of posterior. And when you remember that slide I showed you with all the nice colorful differences, those kind of posterior parietal regions are really responsible a lot of like higher cognitive functions, integration of information, both language as well as nonverbal. Just kind of a little worrisome, frankly. We have found that steroid treatment in particular, but potentially also inflammation is associated with this cortical thinning. And as I just said, these regions play a critical role in higher cognitive and emotional processes and could also be related to the poor school function these kids are reporting. And we do need to kind of like look at this a little bit more, not just what it means acutely, but how do these patients fare more long term. And in terms of the clinical implications, we really got to take a look at this disease that now has younger and younger ages of disease onset, and also is a recurring illness. So we kind of like, it's not something that will go away easily. And I think the worry is more to not just put this one load of steroids towards one inflammation course toward but not flare. But what does it mean if these kids are going to have repeated flares over the course of their development? So we're working right now on ways of how we can maybe identify some of these issues in the clinical setting more easily through maybe like depression and behavior screenings when they come in. And the intervention piece. Medically, the intervention could mean something like adjusting the treatment protocols. So if a patient, for example, doesn't respond well to steroid treatment or other treatment agents, there are two different ways how they can adjust the treatment, and patients are either being put on what's called the step-up protocol, where they're treating more conservatively first, and then they're like getting more aggressive. A newer approach is doing like a top-down approach, where they start treating pretty aggressively in the beginning, because with the hope that they would prevent further relapses and further complications down the road. But before we can do that, we need larger neuroimaging studies, and especially longitudinal studies also, in order to be able to confirm these findings. And eventually, we would like to expand and translate this to other inflammatory conditions, because this was just used as a disease model. And I would probably assume that we might see some similar patterns in other diseases where there's a lot of immune involvement going on. And one study we're doing right now in collaboration with Alan and Alana and Florian is this current study where we're looking at a larger sample of kids with Crohn's. It's still a cross-sectional design, but we are looking at very fancy advanced imaging sequences, and the model really is where we want to look at inflammation, whether or not inflammation has either direct impact on neurobehavioral function or indirectly through red and gray matter. So, and we are also going to be actually doing more like genetic mRNA analysis of our immune markers, which will give us a more fine-grained measure of immune response. And with that, I would just want to acknowledge all of the people that have been involved in that, particularly Chris Watson, who sits over here, who has been pretty instrumental with the neuroimaging component of the study, and all of my lab members and collaborators in psychiatry, neurology, radiology, human medicine. So, and with that, I'm happy to now open it up for questions.
Do you think motion is a problem in terms of causing the cortical thinning in the IBD patients compared to the normals?
I don't know. That would be something that we were controlling for, right?
Very close.
Yeah.
So I have a question for you have a prediction study there. You have already performed a prediction study to predict if baseline predicts. So what did you use for that study? Free sulfur?
I'm sorry, what?
What software did you use for that study? The neuroimaging part.
Pretty separate.
Free
Oh,
sulfur. And then with what software? What did you use to analyze it? What statistics?
Statistics, I use R.
Okay. No, because we have here, so I have developed a toolbox for analyzing longitudinal data, specifically for free sulfur, and also we have recently developed a toolbox that is much better than just normal longitudinal statistical analysis, which is a combination between mixed model and prediction models. What's called no, survival analysis. You heard about this kind of stuff, statistics. Well, they can be combined together, and the prediction power is even more. You can gain a lot of power just by applying these statistics. Because you said that you didn't find much. You expected more, no? To see more on
For TTI, you mean?
Oh, what?
No,
And for the structure, you said it was global,
For
where
the
you would
thing.
expect.
Oh, no, no, no. It was
Thing.
actually, I didn't expect that much, quite frankly, for the cortical thickness.
Okay.
I did not expect that widespread region. I thought it would be a little bit more focused in certain regions. But with TTI, you know, it was clear, you know, how much our findings, you know, are still underpowered, and, you know, seeing more there. So certainly, I mean, if there are other ways, you know, of analyzing the data, if you want to
Yes,
to,
I just wanted to let
Yeah.
you know. It's I remember the models are Cox regression models.
Uh-huh.
They are useful for predicting events based on certain measurements. You can predict onset of a disease, something like that, and they can be combined with mixed models. And I was the one who made these toolbox. I don't know if you go to sulfur list.
You're on the list, right?
Exactly. So I am available. I mean, I'm available to help if you want to.
Yeah.
Just to let you know.
Yeah, thank you.
In your new study that you're going to be doing, are you going to be looking at any patients that have had steroid treatment but then are now in remission to see if the cortical thinning is kind of transient and can be recovered?
Yeah, we do have. So technically, it's like a pooled group again, but because of the clinical feasibility of it all. But we are primarily looking at getting patients who are very active. So we are not so worried about the steroid treatment. They may or may not be on steroids, but we are looking at patients who have high inflammatory markers and those who have low. So they should be in remission, and there shouldn't be any treatment. Yeah.
I just thought if you use the kids like you in the first part of your talk that had the steroid treatment and then were in remission, you'd be able to identify whether it was a steroid factor that was largely contributing to the thing, or whether it's a motive factor. Or other. I mean, there are hundreds of things it could be.
There are hundreds of things, and the thing is, it's always a little bit of a moving target, because when we enroll these patients, for example, when they're active, they may be on steroid treatment, and so the inflammation comes down pretty quickly.
Yeah.
So then it's like you're chasing after them, and vice versa. There could be patients that at enrollment we had them, you know, slated as being an inactive patient in remission, and then I have a flare up. You know, so we're dealing with a bit of the unknown. And you know, our first take will be to do more like regression models, so we can put all these factors in rather than like group comparisons, which are really hard to design in this kind of setting. But there are other factors we need to take a look at. We need to take a look at Remicade treatment, for example. We need to take a look at, you know, what you had mentioned beforehand, you know, other factors like malnourishment, you know, growth, stunted growth, whatnot. I mean, there are a lot of different factors in this disease that could potentially affect.
And also, I want to mention, like, the disease is not just on and off, or just active or non-active. There are tons of stages, right?
Right.
So you should be able to measure the stage of the disease at current stage.
We have measures of disease severity in there that go beyond of just looking at inflammatory marker, but you know how the growth is. For example, it looks at growth velocity. It looks at other markers like anemia. It looks at iron deficiency and whatnot. So.
But I guess if some of the kids have JIA, they're going to have a lot more of a different profile than the kids that have Crohn's on its own.
Although I don't think in our current study they've had anybody in with GRA, right?
No.
Juvenile rheumatoid arthritis.
No. There is a patient right now that I'm talking to who does have arthritis, but he hasn't scheduled any visits yet.
I mean, in general, we're trying to rule out other medical conditions, but something that is like could be related to the Crohn's, it might be something more systemic. We don't want to rule those kids out necessarily.
A question along the same lines. So at least the beginning of the talk, I'm so sorry. You were mentioning Crohn's disease. I know these get chronic steroids, and then you were mentioning irritable bowel disease, acute treatment. What is the dose for acute treatment?
not irritable bowel, inflammatory bowel.
Inflammatory bowel. So
It varies. It depends. So
you were mentioning acute treatment. What do you consider acute?
you mean high dose? Acute just means the patient had a current flare, and then this patient is being put on steroids, most often prednisone.
So I know that, but I mean, it's like 1 day, 3 days, 5 days, 7 days.
No, it's longer than that. So
It's
usually,
longer than
so
that.
we actually wouldn't see in this study. We would not see them until after they would have had to be on steroids for at least a week.
I see.
Because there
Before
is
they
some
come
sort
to-
of in the beginning, and I was not
It's a
saying for any
acute flare of a disease, but it's in reality more of a chronic treatment of steroids exposure. It's not like 1 dose or 2 doses.
No.
It's like
It's
days.
not like in the, the rodent model, the rats when they like inject like 1 day and it's not like
I just want
that.
to understand
Yeah.
that. And my other question is, these kids, do they have any pain medications at the same time?
The kids that were enrolled in the study, not. Sometimes they will put them on like amitriptyline for abdominal pain, but we did not include those patients.
Okay.
Yeah, so there was no significant effect on
So
that.
like,
Yeah.
that would be
Right.
like, I know that pain medicine are bad for
Yeah.
TNF alpha and
Right.
M6 as well, so.
Yeah.
And the reason I'm asking about the doses is because we give kids high doses per kilo for acute treatment at every single dose, and I'm always feeling bad about giving it because I don't know what it's doing. And
I think in order to see a true like level or brain effect, we need to be on this for a while. I did this kind of research with the Dana-Farber beforehand. We're looking at prednisone versus dexamethasone in patients with leukemia, and there you're talking about like really, really high doses for a really long time. And it's cycle, it would cycle you. They would get like a week of steroid treatment, then 3 weeks off, then 3 weeks, and this is over like a year or so.
yes.
And that's when you see the effect. It's like a cumulative.
So compared to that, yours is acute. Yes, I understand.
Compared to that, that's
I
right.
understand.
But most often they will have to treat it for maybe a couple months or so. And our doses were moderate. I mean, it's like 30 milligrams of prednisone. Usually would be the cutoff, but it goes per kilogram.
So this brain change you showed, this is what kind of treatment? This is weeks of treatment or days of treatment?
No, weeks. This would be weeks of treatment. Yes. We can't get them in within days of the start of treatment, just because nobody's going to send those patients to anyone.
No, of course, no.
Yeah.
I understand.
The whole concept of the inflammatory markers causing cognitive dysfunction in and of themselves is really interesting. That we see, similar to that from infancy, to older age. We're really interested in the NICU population too, in terms of and when they get necrotizing endocarditis, then their brain effects are much worse. So there's a really interesting interplay to understand that.
Yeah. But I mean, to your question beforehand about how do you tease apart,
Yeah.
it's really tricky. I
Yeah.
mean, because you have to adjust your model for size. So you need a really large area in order to be able to do that.
Well, I was just talking actually to Mike yesterday about this because we have some of the neonates with stroke. Some present encephalopathic and some don't. And so we're wondering whether the ones that are more encephalopathic, is it because they have more inflammatory markers from more diffuse placental disease versus the ones that aren't. It's just as, isolated to their lung placental changes. So it's interesting.
It will be interesting because I will see these kids cognitively.
Yes. Great. All right. Thank you.
Okay, thank you very much.
We're meeting with Microsoft.
Yes.
Yeah, sure.
Oh, yeah, Ethan and Jane too, studying